Here's the neurology chapter. We'll be talking about some individual um, diagnoses concerning the neurogenic system itself. Also reviewing some of the neurogenic system also. So stroke is the fifth leading cause of death in the United States. So seizures also can occur on all these listed items here. You can have TIAs and full-blown strokes. Autoimmune status is also a common problem, and we usually have to dig down and try to get into why the patient is having an autoimmune status. So we have the central nervous system, which is the brain and the spinal cord, and then the body processes information from the body. The brain does, and then the brain sends signal out for commands through the somatic nervous system and the autonomic nervous system. And your autonomic nervous system is made up of your parasympathetic and your sympathetic. All right, it's responsible for fundamental functions and the central nervous system and the peripheral nervous system. Okay, the brain controls breathing, speech, and all other body functions. The brain still controls the most basic functions, such as breathing, blood pressure control, swallowing, and pupil constriction. Cerebellum controls muscle and body coordination. The cerebellum is divided up into right and left cerebral hemisphere. Each controls activities at the opposite side of the body. And the cerebrum, the front controls emotion and thought. The middle part controls touch and movement. And the back processes sight. Okay, speech is controlled on the left side of the brain or the middle of the cerebrum. That message is sent down the spinal cord. There's 12 cranial cavities that run directly from the brain to the parts of the head. The rest of the nerves join in the spinal cord and exit the brain through the foramen magnum. All right, each vertebrae in the neck and the back, two spinal nerves branch out. They carry signals to and from the body, and the dermatrons, areas of the skin sensation corresponding to the specific spinal nerves, and that's what this picture is showing here. All right, neurons is a nerve cell, and it's a fundamental element of the nervous system. It's composed of three basic parts: the cell body, the axon, and the dendrite. All right, the cell body contains the nucleus. The axon is the projection of the cell body that extends towards another cell, carrying signals away from the neuron. And then you have the synapse, and it's where the interaction between the two neurons occur. All right, the nerve cells do not actually come in direct contact with each other, and at the synapse is present wherever a nerve cell terminates. So it connects one nerve cell to the next cell via chemicals called neurotransmitters. Here's a picture of the neurotransmitters that take electrically conducted signals and relay them to the next nerve cell. There's many different disorders that can cause brain dysfunction and other neurological symptoms. So the brain is the most sensitive change in oxygen, glucose, and temperature. So substantial change in any one of these levels will result in a neurological change itself. So when the blood flow is stopped, the patient will go into a coma. A low oxygen level in the bloodstream will affect the entire brain. It often causes anxiety, restlessness, and confusion. So other brain disorders include infection of the tumor, which may arise seizures and autoimmune status. So there's a lot that can go on with the neurological system. A lot of people have chronic diseases from neuro. Making sure that these patients get to the right facility to assist them in healing from these or continuing to live a meaningful life is very important. You know, you take them to a facility that doesn't offer neuro, you're sort of killing their time as far as being able to recover from whatever. So the first one is usually what we see is a stroke. It is an interruption of blood flow to the brain that is sudden and results in loss of brain function. Okay, so this brain function goes out into the neurosystem because of the blockage or the hemorrhagic stuff. All right, so a substantial number of patients who experience strokes deny their symptoms or do not understand what their symptoms mean. So the longer the stroke continues, the less likely the patient will have a promising outcome. So time is brain in this situation. So this is another situation where medically you don't want to spend a whole lot of time on scene. You want to go ahead and not delay transport on these patients also. Now, without oxygen, brain cells cease to function and begin to die. And this is where you get the infarcted cells of the brain. All right, if a small amount of blood is able to reach the affected area of the brain, it may supply enough oxygen to keep the larger group of brain cells called ischemic cells alive. So there's many different ones. So you can treat these in a timely manner. So it may be from a thrombus, an arterial rupture, or a cerebral embolism. Okay, so the thrombus is that blockage that goes and clots up. The rupture is actually the vessels up there, having a hole in them. And a cerebral embolism is where a blockage travels and makes its way up there. All right, the ischemic stroke, blood vessel is blocked, so the tissue distal to the blockage becomes ischemic, sort of like cardiovascular, like we just talked about in the cardiac chapter. Arteriosclerosis in the blood vessels is often the cause. So this is the calcium cholesterol buildup from inside the blood vessels itself. All right, loss of the opposite side of the movement, side of the body, confusion and inability to speak and comprehend sometimes. Okay. So depending on the location of the obstructions, patients may experience anything from no symptoms to complete paralysis. All right, hemorrhagic results from bleeding inside the brain. People at high risk have chronic poorly controlled hypertension. It's usually kind of often fatal because they can't get to it fast enough. A sudden onset of a severe headache is your main symptom here. You can check pupil sizes and see if one's largely greater than the other would be another symptom also. All right, intracranial pressure, hemorrhagic stroke occurs as a result of bleeding within the brain. As the bleeding continues, ICP increases and the amount of blood available to the brain decreases. And this usually causes a herniation. A herniation is often a shift of the intracranial contents within the cranial vault or displacement of the contents away from their normal position inside the skull. So as it constantly changes, blood pressures fall critically, patient may experience life-threatening issues, and pre-hospital treatment is not effective at decreasing ICP. There's really nothing that we can do in these herniation situations. These patients need to be on an operating table somewhere. Okay, so picture number 1 to the left here is normal. Abnormal is the one in the middle, and number 3 is a herniation or a hematoma starting to develop. All right, TIAs are basically strokes that subside within 24 hours of the cell. However, these are acute symptoms for a bigger stroke happening, or they could be acute symptoms for a lot of other things. Had a patient experiencing a TIA one day, called it in as a stroke. Symptoms started to relieve themselves, couldn't find out they had a mass on the brain. But the nurses were advising me that if I hadn't called it in, then as a stroke, they probably wouldn't have done a head CT. So it kind of worked itself out. So facial drooping, sudden weakness and numbness, decrease or absent movement and sensation on one side of the body, loss of balance or irregular speech, loss of vision, and whatnot are all signs and symptoms. Like dysphagia, decreased level of responsiveness, aphasia, slurred speech, headache, confusion, dizziness, or even possibly a coma. All right, left hemisphere problems may cause aphasia, paralysis on the right side of the body. Right hemisphere problems can cause paralysis on the left side of the body, or your words may be slurred and hard to understand. And then the bleed, of course, is going to cause all kinds of problems. Decrease in blood pressure, um, right? Hypoglycemia, post-stittal state, post-seizures, or some subdural or epidural bleeding may all mimic a stroke. So, just kind of make sure you're checking out these two before you actually call in a stroke alert, just to make sure. The bleeds we're really not going to know a whole lot about unless there's like some type of blunt force trauma. But calling in as a stroke, still going to get that patient there right to go to the CT. All right. All right, seizures. They're erratic firings of neurons. There may be a wide array of signs and symptoms when having a seizure. It could be limited to one hand shaking or a full tonic-clonic seizure where it's full body muscle twitching and moving. All right, there's different types of seizures. Pseudo seizures are those that patients may think that they're having one and they're not. Absent seizures may be actually firing of the brain that has no signs to it. Status epilepticus is a seizure that does not stop. Okay. Here's the different phases that aurora is the cessation, and some patients will have these. Then they go into the loss of responsiveness, and then the tonic phase, and that's the beginning of the seizure itself. Then you get into the hypertonic phase, and then the clonic phase is where you have the contraction of the major muscle groups, and then you have the lip smacking, the biting, and the teeth clenching. Post seizure is the rest period, or the major muscles relax, the eyes possibly roll back, and then they go into the post-ictal phase where everything just kind of rests. Okay, patients sometimes will come back around, and sometimes they become incontinent. So just be aware of that also. Pseudo seizures are generalized neurologic events. May not notice difference from a generalized seizure. All right. Absent seizures, no movement present or a little movement. Usually this is in the pediatric demographic. So focal seizures are you're aware, no change in level of responsiveness, numbness, weakness, and dizziness, impaired awareness, automental status, lip smacking, unpleasant smells, and visual hallucinations. Status epilepticus is a seizure lasting more than 45 minutes. So during the seizure, the neurons are in a hypermetabolic state. So this does not produce long-term damage, but the body cannot remove waste products effective to ensure adequate glucose supply, so the neurons are damaged or possibly killed. So our goal is to stop the seizure if possible, or help protect the patient. Airway is going to be our big concern here in measuring the glucose levels. Here's some common causes of seizures. All right, recognizing that seizures actually occurring, recognizing that post-ictal state and any complications of the seizure, and then look at some problems that may have been causing the seizure itself. They become relaxed in the post-ictal state, almost become flaccid at times. They may have hemiparesis where only one side of the body is moving, and it could be actually resembling a stroke. But a lot of times that comes back around and they're able to start moving it again. They're usually be lethargic, confused. A lot of times when I talk to people in the post-ictal state, I kind of remind them where they're at or asking them if they remember where they're at, and it kind of gives you an idea of what their GCS may be also. So always consider your underlying conditions such as hypoglycemia, possible infection, alcohol, all kinds of reasons. So patient's not thinking clear or who's incapable of being aroused, maybe unresponsive or responsive but confused. All right, autonomic status, here's your different list there. Hypoglycemic can mimic a stroke or even a seizure. So just make sure that you're checking that. Try to fix that before you actually call in, the autonomic status or the stroke alert. So that way you've got rid of one of the possible causes. Okay. Hypoxia and all these other ones. Drug overdose, same thing. Just if you want to administer Narcan or antidote, just to make sure that's not what's going on. So adverse effects on medications. Some people take too much of them. Some have that synergistic effect where they've taken multiple together and they're all kind of crashing down on each other. So be mindful of that too. All right, fainting is just a simple episode, temporary loss of consciousness. It could be life-threatening if that dysrhythmia occurs, or even can cause a stroke or other serious medical problems. Here's the list of causes for those two. Headache, there's many different kinds, many different reasons a person could be having a headache. Just getting OPQRST there, see if anything makes it better. Maybe it's the light. Maybe you turn off the lights and kind of cool things down a little bit. That patient may be getting better. All right. In your patient assessment, the brain is sensitive to fluctuating levels of oxygen, glucose, and temperature. So trying to identify that neurological problem is to look both obvious and subtle changes. So sync size up. If you're positive for a stroke and you've got a long transport time, there's a lot of studying on this too. Some people are actually going up to 24 hours, being able to go in there and remove the clot in that large vessel occlusion. So there's kind of multiple decisions that have to be made there. But when in doubt, brain is tissue and you don't want it to become hypoxic for a very long time. So consider air medical if you need to. All right, let's decelerate the corticate. So note the patient's body position while they're having a seizure or while they're presenting with the autonomic status. If they're decorticate, that patient contracts the arms, curls towards them, towards the chest, and decelerate. Patient points away. Decelerate is a more severe finding, and it's due to the location on the brain where that abnormality is. All right. So all these patients, you need to be concerned with their airway status and breathing status. That seizure patient, that hypoglycemic patient, probably could use a little bit of supplemental O2, just because of the hypoxia that may have occurred during the episode. So, and then in their circulation, of course, if you don't find a pulse, immediately start CPR. So unstable patients should be transported rapidly to the closest appropriate facility. If it's suspected of having a stroke, transport to a stroke center, give an advance notice, give that heads up and stroke alert pretty soon. They won't want to know a race score in your men's score also. So have that ready and just be prepared to, walk into like a trauma situation at the hospital. Get your history from your sample, see if they've ever had one before, when the last one was. Is this something that's intermittent, stroke-like symptoms or seizure symptoms? And that kind of gives you an explanation there. So look for the fast making mnemonic as far as the stroke is concerned, and then a race score if you have access to that information. Perform as soon as possible. Identify a stroke is imperative Also look for any kind of trauma injuries. So to see if, possibly there's something happening there, then we had a trauma episode, and then we, possibly got a bleed there from the blunt force trauma. GCS score is going to be also very important. Most people use the Los Angeles or the Cincinnati together. On the men's score, strokes scales also out there, and with the race score. Entire COT is important, pulse ox is important, and just make sure you got a blood glucose. All right, not a whole lot we could do for these patients. 2 IV access, just so they'll have both of them. Hopefully, you do those on the arm that is not affected. Try not to do them in the arm that's affected. However, if you don't have much for choice, you kind of have to do what you have to do at times. And the theology behind that, the thinking behind that is, the clot is on the opposite side, so it may travel around to that side of the brain, whatever you push through that IV site. So, all right, maintain your ABCs, check your heart for hypoglycemia, glucose, glucagon if needed, and then go from there. So, IV access, elevate the head to 30 degrees, airway clear. A lot of these patients, once you get to the hospital, hopefully they'll go straight to the CT scan and they can go ahead and make those quick decisions there. Here's the adult suspected stroke algorithm from the American Heart Association. TIAs usually relieve themselves pretty quickly. Like I said, I was telling you before, I had that patient with a mass on their head that had a TIA in front of me. But this actual stroke center advised that once you called in a stroke, they did not call it off until you got there. All right, you need to suction these patients, keep them safe. If you while they're having a seizure at the advanced EMT level, it's not a whole lot you can do to them. Please don't put your fingers in their mouth. Please don't put a bite stick in their mouth anymore. So just do what you can. Call for a paramedic backup if you can get an IV access. Do that, but also make sure you're checking their sugar too. Syncope 12 lead is the most important thing here at a glucose check. It could be a sign for some major underlying conditions. And then a headache. Just follow your headache algorithm in your protocol.